All right, good morning, everyone. Thank you for attending today's HAI seminar. Today is November 18th, 2020. My name is Amit Kaushal. I'm a clinical assistant professor of medicine at Stanford and adjunct professor of bioengineering. And it is my privilege to introduce today's speaker. In my own graduate training, my advisor once said something that stuck with me. The one way science advances is when knowledge from two different disciplines enters the brain of one person. And that is very true, and particularly when one of those disciplines consists of problem-solving tools, and the other discipline consists of problems worth solving. And I think today's speaker really embodies that. So it's my privilege to introduce Dr. Sherri Rose. Dr. Rose is an associate professor at Stanford University in the Center for Health Policy and Center for Primary Care and Outcomes Research. She is also co-director of the Health Policy Data Science Lab. Her methodological research focuses on machine learning for prediction and causal inference. And within health policy, Dr. Rose works on risk adjustment, algorithmic fairness, comparative effectiveness, and health program evaluation. She was recently named a fellow of the American Statistical Association, and her other honors include the iSport Bernie J. O'Brien New Investigator Award, an NIH Director's New Innovator Award, and mid-career awards from the American Statistical Association and Penn-Rutgers Center for Causal Inference. We are thrilled to have Dr. Rose at Stanford. She recently joined in August, so please let's give her a welcome. And Dr. Rose, I'll hand it over to you.
Thank you so much. I'm really healthcare with my subtitle, Too Important to Be a Toy Problem. And talk goes on, you'll see a lot of the concepts and themes that I present exemplify why we cannot have healthcare treated as an example in a paper when we're developing new tools, and how we have to really understand these issues in healthcare in order to genuinely solve problems in human health. So I'll be offering perspectives on challenges in data science in the healthcare space, as well as centering, avoiding perpetuating harm to marginalized groups. My research in machine learning for healthcare focuses on health economics and health outcomes that can have an impact on health policy. And when we think about machine learning in healthcare, it is not always from this perspective. So there's one thing that my research brings to this gap. And as a PhD trained statistician, what I bring to health policy are machines that take data and investigator knowledge as an input, but we have a priori specified benchmarks in order to reusing. And underneath the hood is a methodological grounding in theory. But we also want to make sure that these tools are flexible enough to handle the large data sets that we have in health policy. So if something is theoretically optimal, but it is not computationally feasible, that's not going to be something that's useful in my work. I wanted to lead off this presentation dovetails nicely with what Amit was just talking about. Learning two fields takes surprisingly twice as long as learning one, but it's worth the investment because you get to solve problems for the real time, for the first time. And over time, I've equally become a health services researcher. And because I've done that dual training, that we have a lot of buy-in from people. But I think we also need more people. And I know that's something that Stanford embraces with many of the PhD programs, for example. The second quote, in both private enterprise and the public sector, research must be reflective of the society that we're serving. I think this is something that we need to be really cognizant of when we're building teams, that we don't have homogenous teams. Who's asking and answering questions can have a huge impact on individuals who will face repercussions from those tools. And the questions that we choose to examine are really driven by who's on that team, and then how we evaluate it, and in the entire machine learning pipeline. A first-year graduate student at UC Berkeley And it really, it stuck with me then and up until now, and I think is incredibly important. As a human story, there's a full underlying these data. Speaking of data, one of the slides that I've had in my presentations to health researchers. And what I used to say is that the general usefulness of this type of data to answer targeted scientific research questions is an open question. But now I think it's generous at best to say that it varies. There are many data sources that will not be useful to answer certain types of research questions that we may have. So for example, healthcare billing claims, which I'll talk about more in a moment, is often not suitable to answer questions of a causal nature because there's many things that we haven't measured, unmeasured confoundings, clinical information that is not available in billing codes. So one thing I like to stress in my research where I do develop new machine learning tools is sometimes we don't need a new tool. Sometimes we can't even use an existing tool because the data sources available to us will not be suitable for the research question that we're trying to answer. And we need to be okay abandoning data. We cannot necessarily always make data work for the problem that we're trying to answer. So as much as I love to develop novel statistical tools that have desirable properties while remaining computationally feasible, that is not always what is needed. So I just mentioned billing claims, and what I have on the title of this slide is EHR does not equal EHR. So EHR stands for electronic health records. And a lot of times we see EHR in journal publications and other places haphazardly sometimes and not non-specifically. And many papers that refer to EHR are actually using billing claims. And we know that billing claims have very large sample sizes, but as I just mentioned, they often lack clinical information that we may need to answer certain types of questions. Whereas the clinical records in a second bucket will have that clinical information, but may be difficult to integrate across systems. And you'll see that I have a darker, newer data sources and that we're just starting to, in the healthcare space, integrate and study in our analyses. And these buckets are not mutually exclusive, and you could have individuals potentially, you could have different data sources potentially in more than one bucket, and they're also not exhaustive. So there may be other buckets that we could add. And imaging is one of those that could have been included in the digital bucket, for example. With registry data, we have even more deep clinical information about specific diseases, but we often only have short-term outcomes, although we may be able to link to vital records, for example, in order to have longer-term outcomes. Survey data can be incredibly useful because we can sometimes even design the survey to really suit our research question, whereas using something like billing claims. But with surveys, we typically have much smaller sample sizes compared to these other sources, and we may face issues like recall bias. With government data sources, we often don't have data at the individual level, but we may have some unique information that's not available elsewhere. Government data sources are often linked to some of these other data sources so that we can bring that unique information to a clinical records database, for example. There's often, as with all of these data sources, bias built into our data, societal bias. So if we were going to use crime statistics from a government data source, we need to be very aware of the societal bias that's built into that data. Moving into these newer buckets, wearable and implantable technology may offer really exciting granular information on movement. So if we were thinking about trying to measure leisure time physical activity in a survey, we're going to have that recall bias. But with an accelerometer like a Fitbit, we will have much more granular information, but we need to be aware that there's also oftentimes measurement error. So we might be with digital data, this type of data can often be noisy, but we may have information in digital data search data, Twitter data that's not available elsewhere, in places where we don't have high quality information on specific types of populations or in specific geographic regions. And oftentimes people are more skeptical of some of these newer data sources. And I believe that we should be skeptical of all of our data sources. But one thing that is often neglected to think about is if we limit ourselves to some of these more commonly used sources like billing claims and clinical records, there's individuals that won't be studied because they don't have an encounter with the healthcare system. And so using some of these other sources allows us to include people who would otherwise not be included. And then lastly, I have on here news media data, which has been very useful in outbreak detection. It's not going to have the same kind of lags that a billing claims database or a clinical records database would have when we're dealing with infectious disease. And kind of looping that together with billing claims, I recently wrote a piece with my former postdoc, who's now faculty at Boston Children's Hospital and Harvard Medical School, Maya Majumdar, where we've been working on a number of projects on different types of data synthesis and bringing different data types together for infectious and chronic disease. And we were worried as we started seeing this second wave of research in COVID-19, where people are starting to use individual level data to study different types of outcomes. And one of the things that we discuss in this piece are many of the limitations of healthcare claims data that a lot of people are not aware of, who have never used them before. And we have a lot of people who are very well-intentioned trying to solve problems in the COVID-19 space. But what we did here was we tried to highlight the limitations and then some of the potential opportunities to use billing claims. But for example, studying treatment efficacy in a billing claims database is going to be very, very difficult and is not necessarily a recommended use case given the information that we don't have in that database. And I'll come back to some of these limitations throughout the talk as they crop up in other themes and sections. So the next area that I wanted to discuss is the broad theme of generalizability. And often when we talk about generalizing studies, this is in the context of inference, where we might have a randomized trial that we want to generalize to a target. Or maybe we would like to generalize one of these studies to another target population and transport that effect to, for example, another state where we've studied something in New York, and now we'd like to transport that effect in Massachusetts. And so I've been working on a number of machine learning and AI-based methodological projects in Medicaid with two wonderful collaborators who are leading this work. Irina Degtiar, who's currently a PhD student at Harvard. She's graduating in the spring, and you should hire her. And then my former postdoc, Austin Dente, who's now an assistant professor at Tulane. And I'm really excited about this work that we're developing. But one of the things that I like to highlight with generalizability is that we need to really be thinking about this in the prediction and clustering space and other research questions as well. So prediction, clustering, and inference doesn't capture all the types of statistical questions we could ask. But one of the things that is very concerning about the lack of generalizability in a lot of the machine learning and healthcare research is the fact that these tools can have a direct impact on individuals' lives. And so we need to have an incredibly high standard. A lot of the research that we see coming out, particularly in clinical journals, is we have some machine learning tool that outperforms a standard regression by a very small amount with respect to something like AUC or R squared, which is a global fit metric. And they used maybe 1 year of data in a single medical center. And there are often claims about how this deployed. And it's really not ready to be deployed because there's typically no external sample. Again, these global fit metrics are very limited. We often see with machine learning and healthcare, we have these AUC leaderboards or an R-square leaderboard or some other leaderboard based on a single metric that can really mask problems in the algorithm. So not only can you have a really, really small true positive rate accompany something like a high AUC, but we also haven't, again, examined the impact of these tools on marginalized subgroups. And so we need the research to really be shifting and moving towards having external samples, having more exhaustive evaluation, and not making really broad claims, especially in healthcare. And I don't just see this in the clinical literature, in health policy and health services research. We're seeing more of this, and also in the economics literature. So these are just the spaces that I work in. This is something that we could dive into many different literatures and see these same problems. And a couple of years ago, I wrote a commentary encapsulating some of these issues and things that we need to do, including having rigorous standards for cross-validation. But I also mentioned something that the machine learning researchers who develop novel algorithms for prediction and the clinical teams interested in implementing them are frequently and unfortunately two non-intersecting groups. So this is, again, it would be, I think, really helpful to the field for us to have not only team science, but more people who are dual trained. But what we're seeing in the literature is we're very far from being dual trained. We have oftentimes statisticians and computer scientists and machine learning researchers working on a problem and then throwing it at a data set. And then on the other side, we have substantive and applied researchers and clinicians who are working on an applied problem without the sophistication of deeply understanding the tools. And we want more examples of people coming together. And so we can have much more rigorous research, again, because our field is so incredibly important to have that high standard. And so that's not to say that there aren't people in this space who are doing that. And there are a lot of initiatives to try and bring people together. But this is still a massive problem in the healthcare space. So I wanted to talk about dataset shift in the areas that I work in and how this comes up. So this is where we have the input data changing after the algorithm has been deployed. And so sometimes we can see we have a tool that's maybe been developed in a particular hospital to be used in that hospital. And the population that goes to that hospital changes over time. So now that the data set has shifted. But what we see in a lot of the healthcare data is data set shift that occurs for other reasons. So we often have misclassification and disease status for many different reasons. There's many reasons why someone could be missing a code. There's many reasons why somebody could have a code and not actually have that condition. So one example of this, I have a figure here from some work that of ours from a couple of years back, where we're looking at individuals with chronic condition. How many of them were coded for that condition in year T+1? By type of chronic condition, individuals with type 1 diabetes are persistently coded about 93% of the time. But then if you look at something like paraplegia, less than 60% of people who were coded for paraplegia in year 1 were coded for it in the subsequent year. And so this is just one example. Frequently had people refer to me, oh, claims data is a gold standard. And these codes are not gold standard codes. Just because somebody has a code does not mean they have the condition. And here, somebody's missing a paraplegia code does not mean that they are not paraplegic. And so we need to be really thoughtful about the way that we use these data and understand the limitations that underlie using billing codes. So the next section I have is called familiar question, different problem. And what I mean by familiar question is that from a technical standpoint, these optimization questions or the statistical estimation question will be familiar, but we're applying it to different problems in the health economics space. And so for those of you who are not familiar with plan payment risk adjustment, I have a brief overview on this slide. So this plan payment risk adjustment system was designed to redistribute funds based on health. And the idea is to encourage competition based rather than health insurers avoiding high cost enrollees. This has massive financial implications in the healthcare system. If we think about an average enrollee, may cost around $6,000 a year. With over 50 million people in the United States currently enrolled in an insurance program that uses risk adjustment, this is hundreds of billions of dollars. And the massive size of the healthcare sector means that risk adjustment is arguably one of the most consequential applications of regression for social policy. So we'll recognize this as a prediction question. We have our spending outcome Y, we have our input vector X, and then we have our coefficient vector theta. And what we can see here is that our input vector, which will contain in most cases, many different binary flags. So we'll have billing codes that have been aggregated up to something called hierarchical condition categories, which is what is often used in many of the US systems. So you'll have a flag if you had a code that falls within that hierarchical condition category. Then we also have different age sex bins that will also be binary flags. And the more flags that somebody has, the higher the payment will be to the insurer. So this creates an incentive for insurers to have individuals in their health plans have as many flags as possible. And so typically this would be done in a legal way. So we want to have as many people who have a condition, have an encounter with the healthcare system so that they have flags for those health conditions. That's the incentive for the insurer. There are also illegal forms of this phenomenon called upcoding that are incredibly problematic. But even the legal forms of upcoding can create issues in the healthcare system. And so in trying to combat this incentive for upcoding, when I started working on risk adjustment about 7 years ago, there were some ideas from the machine learning world that I thought could be brought to this problem. And I didn't think it would instantly solve the issue of upcoding, but I thought there were some things that had potential that hadn't really been tried yet. So in one of my early papers, I ensemble machine learning, so bringing multiple algorithms together in an a priori specified way and build variable selection within the cross-validation. And we reduce the number of variables. That gives fewer opportunities for gaming the system. If we reduce the number of variables, there's fewer incentives for upcoding because there are just fewer codes that can have an impact on the formula. And so I'll come back to that because there's many reasons why we may not want to remove codes from the formula when we talk about issues of making sure the algorithm is fair. So I looked at this as a pilot to see what would be the impact of doing this, and definitely did not say it was ready to be deployed. What I found was surprising was that a reduced set of just 10 variables instead of dozens and dozens, and some of these formulas actually have hundreds of variables, was 92% as efficient as using the complete formula. And this was in using data from a commercially insured population. This is the same data to build the risk adjustment formulas for the health insurance marketplaces from the Affordable Care Act. So that was one of the important aspects of using this data source is it is the same data source that's actually used in practice. But what I mentioned in this analysis was that we had replication studies in other populations, including Medicare ongoing. And because it's 2020 and ongoing was some years ago, that replication study was now completed. And what we found was that this not only did the result not generalize, so the particular 10 variables, but the process didn't generalize. Building a tool that did variable selection in Medicare did not work. We could not use and refit the algorithm in this new data source and build a tool that had good performance. So what we found were that results for the risk adjustment algorithms that considered a limited subset of variables performed consistently worse across all benchmarks. So using the data and refitting the same kind of process where we do variable selection did not generalize in this older population. So Medicare includes individuals over the age of 65, as well as individuals under 65 who have disability insurance or who have end-stage renal disease. And this is really important because a lot of our studies in healthcare often exclude individuals who are older adults. And so many of the samples that we might be working with do not include individuals over the age of 65. And so you may not know that either your process, your algorithm, if refit on new data, or the fixed algorithm, you may not have any sense whether that would generalize in an older population or not. And so I wanted to highlight both of those things because sometimes the fact that the process didn't generalize is surprising to people, but also have us keep thinking about which populations are being marginalized in the healthcare system. And I'll be coming back to this in some later slides. And so that brings me to talking about the issues within fairness. And fairness is a very broad topic that we could talk about many different aspects. I'll only touch on a few today, but similar to generalizability, issues of fairness cross all research questions. And while much of the work has been done in prediction, we also need to be thinking about fairness in clustering, fairness in causal inference. And some of the questions that we might need to be thinking about, this is not exhaustive. Again, who decides the research question? Who is in the target population? What do the data reflect? Again, we know that our data reflect things like structural racism on individuals who are low SES. And then lastly, how will the algorithm be assessed? And so there's been a lot of incredibly foundational work in algorithmic fairness in other spaces. So for one example, the Gender Shades project demonstrated much poorer classification accuracy for women versus men among 3 different commercial facial recognition products, and especially among darker skinned women. And so this was, you know, an incredibly problematic finding. And again, it was because they made sure to look at different subgroups and who would be harmed by this technology. And there are parallel and analogous issues all throughout healthcare, sometimes with respect to performance on different subgroups, but then again, hearkening back to some of those other questions, also who's in the target population. So when we think about clinical trials in the healthcare system, oftentimes they're centered as being primary. Again, they're a gold standard. But one issue that we see in many of our clinical trials, and this is from a report from ProPublica from 2018, is that they found that Black people and Native American people were underrepresented in clinical trials, even when a treatment was aimed at a particular type of cancer that disproportionately impacted them. So in one example, there was a particular cancer type where 20% of the population that's impacted are Black or African-American individuals, and yet only 2% of the individuals enrolled in the clinical trial were Black or African-American. And so we really need to, again, think about who isn't being studied, which target population does this generalize to, and what statements can we make, and being really thoughtful about the entire process of studying different, you know, whether it's studying different treatments or studying the impact of a tool on the population is who's in your sample, who's in your target population. And we also, again, know that this is an issue for older adults. There was a recent study that just came out with COVID-19, where they found that older adults are likely to be excluded from more than 50% of COVID-19 clinical trials and 100% of vaccine trials. And this is, we know that this is a problem because over about 9% of our population in the United States is over the age of 65, and we have 30 to 40% of the cases among individuals over the age of 65, and 80% or more of the deaths are in older adults. And so again, we need to think about who is being marginalized by the healthcare system. When we start thinking about the algorithms that we're developing, we can formalize this in algorithmic fairness. So a typical problem in computer science will have an outcome Y, a vector X that includes a protected class or sensitive attribute A. And again, a lot of this work has been done in the context of prediction. So the goal may be to create an estimator for the function of X equals Y, while ensuring that that function is fair for A. And there are many common measures of fairness that are based on the notion of group fairness, striving for similarity in predicted outcomes or errors for groups. And so we could think about, if we think about our sample as falling within this maroon rectangle, there may be a protected class within this yellow rectangle that we're interested in calculating fit metrics for, and defining group fairness metrics for individuals in that group. And so we can calculate those among those individuals in that group. And then we could also calculate that same metric in the complement groups, everyone outside that yellow rectangle in the G complement, so G to the C. And in the risk adjustment space, one of the metrics we might be very interested in is something called net compensation. So that's and their observed spending. So if we take the difference of your predicted spending and your observed spending, and that's negative, that means your predicted spending is too low. That means the insurer would be undercompensated for you as an individual. Now, if we think about this at the group level, if there are groups where their average spending among that group, so if we average among everyone in this yellow rectangle, if that number is negative, that means that the insurer is going to be undercompensated for individuals who are part of that group, and that creates incentives for them to discriminate against that group. And we know that unfortunately plans are able to discriminate at the group level. So this has particular salience for risk adjustment in mental health, because we know that changes in financing and the organization of mental health care, not new treatment technologies, made the difference in improving mental health care from 1950 to 2000. How we manage the financing of mental health has major implications for health overall, with 1 in 5 individuals in the United States having a mental health condition. And we also know that mental health costs overall are substantial. We know that mental health conditions are number 1 in total cost. We know that they're number 2 in spending growth. And so in some of our other work, we also found that unfortunately, in that the risk adjustment system that I mentioned for the health insurance marketplaces, that system only recognizes about 20% of enrollees with mental health use disorders. So this now incentivizes the insurer. This is a group of people who have higher than average costs, and now we know that they're undercompensated. They're not recognized by the system. So individuals with mental health and substance use disorders can be systematically discriminated against. And the ways that plans can do this is they can change the benefit design of their plans. They can put drugs that are needed for a particular condition like mental health and substance use disorder in a higher tier in their drug formulary. They can change their provider network such that certain specialists will no longer be available. And so one of the things that, so I've done a lot of work in this space, and one of our recent projects that I worked on with current Harvard PhD student in a zinc, statistical machine learning regressions that loss function. And what we saw was that compared to an ordinary least squares, which is standard practice for risk adjustment, we saw really minimal drops in overall global fit. But we saw a massive improvement in net compensation. So we started off nearly $2,000 undercompensated of mean spending, and we got down to negative $46. So again, this is a 98% improvement. And in subsequent work that recently came out as an NBR working paper, we saw that bringing together fairness, these type of fair regression techniques, not just for one group like we have here for mental health and substance use disorders, but for multiple groups, bringing in that variable selection that we were interested in using because of upcoding and other reasons that we might want to reduce the number of variables. And we brought in some other things in the risk adjustment space to try and get us closer to policy recommendations. But it was really exciting to see that bringing these algorithmic fairness considerations for 4 groups instead of just one improved fairness for 88% of the other groups that we examined who were not optimized in that loss function. Because that's one thing that we want to consider is if we center certain groups for fairness consideration, what happens to the groups that are not centered? Are they going to be further marginalized? And so that was a really exciting additional finding in our subsequent work. And I want to end this section on fairness by just highlighting a recent paper that I worked on with just a team of brilliant women where we wrote about ethical machine learning in healthcare, and we built an ethical pipeline, again, starting all the way from problem selection and not just who decides what the research question, but also this issue of disparities in funding and what type of work is funded, and going through all the steps that I mentioned here, data collection, outcome definition, algorithm development, and post-deployment considerations. And so it was really delightful to work and learn from this team. If you're interested in building an ethical pipeline into your machine learning, this paper is available on arXiv. So in my last section, I want to touch on policy and practice. And here I have an example that brings machine learning to a causal inference question. It also brings some other considerations that we'll talk about in a moment when we think about what this would mean after the fact. Once we have a finding like this, what does it mean for policy and practice? So one thing that you may have seen about medical devices is there are often a lot of headlines about how your medical device may kill you. And while these these could be considered clickbait headlines, they are not as far removed from the truth as many clickbait headlines. So this is something that we are concerned about with medical devices because we do not have a national medical device system in the United States. So we don't collect information to distinguish devices. That this information is not routinely collected the way that it is for prescription drugs. We know that implantable medical devices are high-risk treatments that are studied in small trials. These devices change quickly over time, and they can also have really serious side effects, including death. So my colleague Norman and I were interested in studying the safety outcomes for particular types of cardiac stents, because it tries to prohibit cell proliferation. And so bare metal stents do not have this drug coating. But usually they're grouped together. And we know that there are differences between devices among drug-eluting stents. We wanted to understand the comparative effectiveness of different types of drug-eluting stents, which had not been studied before. And we did this in a percutaneous coronary intervention cohort where we had claims data linked with clinical registry data, and bringing us back to the beginning of the talk, we linked to vital statistics so that we had long-term outcomes. And what we found was that there was a heterogeneous impact for a safety outcome, major adverse cardiac events, including death, in this PCI cohort. So the best performing stent, which is all the way to the left, C1, and the C represents the manufacturer, had, these are anonymized, so C1 and C3, the worst performing stent, are the same manufacturer. But the C1 stent had around 6% of its expected outcome was about 6% of people would have a major adverse cardiac event, and C3 was nearly 25%. So this is a massive, massive difference. And you can see that if we had grouped by manufacturer, we would not have seen this. And one of the things that was also interesting about this study is this is an example where bringing machine learning to causal inference made a difference, and also double robust estimation, where we don't just use the outcome regression information, we also use information from the propensity score. So as bringing all these things together was how we were able to find these effects. The estimators that did not do both of those things, both the machine learning and the double robust estimation, did not identify these differences. And we were able to reproduce this in a simulation study where we know the truth, such that we could have even more confidence in our findings. But that said, I will say this was a study that was conducted within Massachusetts, so there's more work to be done. Would this generalize to another state? That's something we don't have the answer to. And so, but this finding was not necessarily something we expected to see. We were concerned that this might exist, but we did not know that we would see such a huge difference between devices. And there's reasons why C1 and C3 could have such a different safety profile. They were approved 4 years apart. They have different polymers and different stent delivery systems. So there's reasons under the hood of why we could find this. But there's lots of questions that we might want to ask after having a finding like this. There's implications for patients, hospitals, manufacturers, and regulators. I won't go through all these questions. This isn't an exhaustive list, but I mean, thinking about how to communicate this information to patients, thinking about contracting with hospitals and different manufacturers and trying to avoid poor performing devices, there's so many different questions that we could ask. And so to wrap up in closing, I wanted to highlight a recent piece that came out examining racism in health services research. So health services research, the area that I work in, where we're studying cost and quality and access and health outcomes in the healthcare system. So this is a really important commentary piece talking about how we need to acknowledge the impact of white supremacy in health services research in the way that we ask and answer questions, and just, again, throughout the research pipeline. And that paper is available, free access. I encourage everyone to read it. And then I also have, if you're interested in learning more about the intersection of machine learning and health services research, and also epidemiologic methods for causal inference and for prediction, I have a paper that is open access and available if you're interested in learning more about some of the research questions I didn't talk about today. And so lastly, I want to ask you to think about, does your algorithm have a social impact statement? Who's responsible to users if they're harmed? Is it explainable to users? How accurate is it? And how are you measuring accuracy? Is it auditable by a third party, both the data and the algorithm itself? And there's lots of issues related to privacy there. And then lastly, fairness, which is a topic that we touched on today. And I want to make sure to acknowledge some of the wonderful former trainees and current trainees that I've worked with. Many of their papers have been cited throughout this talk. I also want to acknowledge my funding. And if you're interested in learning more about the Cite Black Women Initiative, my shirt, which was founded by Dr. Kristen A. Smith, I have the website here, citeblackwomencollective.org. And so that is the end of my talk. And I'm going to stop my slide share so we can do our Q&A.
All right, thank you very much, Dr. Rose. We covered a lot of ground there. To the audience, if you look in your chat window, you'll see a link to the Q&A site. Please put your questions there. I'll read some questions verbatim or get the essence of others and try to get as many as we can to Dr. Rose. I'll start out with one, Dr. Rose. Early in your talk, you mentioned the nuances of different data sets and the importance of using the right data for the right problem. For people who do research in this field, it seems that there are two ways to approach it. One is we find a data set and we say, what questions can we ask of this potentially interesting data? Or we start with a problem and we say, does appropriate data exist? And if not, do we have to generate the data? Often a much longer, but probably more representative effort. And so in the work that you see in the field, how often do you see these two different approaches being used, and how do you counsel practitioners who may be listening to using one approach versus the other?
That's a great question. I do see a lot of both. And I think people who are really driven by having a passion to solve particular questions in healthcare, a lot of times those are the teams that are coming and saying, this is the research question. We need to find the data that we need in order to try to answer this research question or one like it. So sometimes it's not always that you have to completely abandon a research question. Maybe it's you have to redefine your target parameter of interest because certain things weren't measured, or maybe you can estimate a conditional effect instead of a marginal effect because of the data type that you have. I think one of the problems with the other example that you mentioned of, oh, here's a data set, what kinds of questions can we ask? Sometimes that can result in really important is you might be asking a question that you don't necessarily have the expertise to ask. And so if it's, oh, wow, we have this data resource and we usually don't have this particular measure and I've always wanted to ask this question, that's different than, oh, wow, look at all these different variables. I'm going to study something that I'm not familiar enough in order to necessarily formulate the right question. And so this is something that I would recommend caution against that. And so sometimes maybe it's build out your team so that you can formulate a better question, maybe somebody who's an expert in that particular disease, but being really thoughtful, because again, treating a data source, sometimes I meet with people and I ask them what their research question is, and then they just keep talking to me about their data, and they're so excited about their data. And sometimes I get really excited about data too, but if telling me exhaustively the variables you have without thinking through and formulating what that research question is, I think taking a step back is really important.
Great, thank you very much. So looking through the questions, lots of questions, concerns about algorithmic fairness, and what can we do to mitigate particularly racial bias in algorithms. So there's some suggestions here about having standardized benchmark data sets, others to try to, should we get the government involved to try to regulate some aspects of this? And so maybe I know you covered a bit in your talk, but for the concerned individuals in the audience, what kinds of steps can we take to promote algorithmic fairness?
This is a great question, and I will not claim to have all the answers. There are a lot of people doing a really tremendous work in this space. You know, there's the Algorithmic Justice League, and there's a lot of really important racial justice initiatives within the machine learning space. But I would say the actions needed often depend on the context. So sometimes when we're talking about facial recognition, sometimes that does become legislative where they ban facial recognition in certain cities. Within the healthcare space, we often have regulation associated with certain types of treatments. And so if we're thinking about the impact of a particular medical device or particular treatment on individuals who are marginalized by the system, by Black individuals, then, you know, having a more comprehensive set of benchmarks and standards could be one approach. I think the other issue that came up in the talk is the composition of your study. So many of these studies for treatments are 95, 98% white, 92% white, and you can't justify, you can't make claims about performance and how this might have a bad outcome or a bad impact on Black and African American individuals if they're not in your study population. So having a more rigorous standard in order to reach that bar. So when I talked about that clinical trial example, there was one company who had a really dedicated team for enrollment, and such that they actually had appropriate numbers of individuals who are Black and African American in their cancer clinical trial. So creating those incentives in the system and creating those benchmarks is just, you know, another avenue that we can approach. But it's impossible to answer that question in a complete way in a short period of time. But also I do want to say there are tons of other experts who are working on this that I would recommend. I included some references in the talk, but also that paper that I mentioned, the ethical machine learning in healthcare. We cite many of the leaders in this space, many people who are also working on this and try to prevent the deleterious effects of racial bias in healthcare.
Thanks. A related question, maybe not from the algorithmic side, but from the clinical disease side. There's concern or questions in the audience about the potential for machine learning to impact rare diseases that affect predominantly underrepresented populations. So there you have two challenges, right? The lack overall of prevalence of the disease, and then the systemic issues that work against underrepresented minorities. And for people interested in those disease areas or health services, do you have any recommendations or guidance?
So one of the things that I'm glad is getting more attention is the focus on funding priorities, because one of the things that has been really difficult in studying rare conditions and conditions that are rare that disproportionately impact Black and African American individuals is the lack of funding and the lack of resources given to researchers to study these conditions. And there's been much more of a push and much more of there's been a number of studies come out, and the NIH has started to respond to this issue of not only are these types of studies not being funded, but individuals who are Black and African American are getting funded at much poor rates because the topics that they're interested in studying are not funded at levels that are as high as the others. So that's one thing that I think we can do more to push to have better funding for those conditions. And that can help to have the people who are already expert in those conditions to get more funding in order to do expanded research. But I completely agree that there's a lot of potential for harm in thinking about bringing machine learning to some conditions that are understudied or conditions that are rare that disproportionately impact marginalized groups, that if they have not been studied in those contexts, they should. I highlighted this issue of being very cautious in healthcare in particular. So these papers that we see that have these tiny improvements, we need to be really thoughtful not to say that those can be deployed before we've given a lot of evidence to demonstrate that it's necessary or that it's an improvement. And again, who is it going to impact? But so I appreciate that question. I think I'm glad that many in the audience are thinking about these issues, because the more people that are considering it, the fewer projects and studies we're going to have that are incredibly problematic to people who are already being minoritized.
Great, thank you for that insightful response. I want to ask a question about your risk adjustment work at a higher level. When you think about machine learning for healthcare to solve address a clinical disease, we're trying to predict fundamental biology or medicine. And the better our predictions get, the better we expect to do in addressing that disease. In risk adjustment, the more successful we are, the more people are going to try to game the system and counteract whatever patterns we find in the underlying data. And how, from a methodologic level or anywhere in the research pipeline, are these similar problems, or because of those different dynamics, do you have to address those totally differently?
Yeah, that's a great question. There's a lot of things to think about in risk adjustment, where sometimes, so I've had people tell me that bringing machine learning and AI tools to risk adjustment won't happen because regulators and policymakers want to understand what's happening. And if you can't have a really explainable tool, that's going to be a problem. And then others who say, actually, it's good if this can be more black box, because then it's more difficult to game. And so I don't actually take a position on either sides of those, because I see both issues. Because one of the things that we have a lot less of in the risk adjustment space is any direct transparency to what people would call users. And here in the health insurance system, a user is an enrollee. Most people who are enrolled in a health insurance plan have no idea whether risk adjustment is used in that product. And so it's not transparent to the people who are going to potentially be discriminated against at the group level. And so I think our considerations do need to sometimes be different. That's one of the reasons why I thought the idea of bringing certain techniques from machine learning into risk adjustment, like something as straightforward as variable selection, could have a much different, have a very different impact in risk adjustment than it would in another setting. So if we're in an ED, in an emergency department, and the idea is we have a 5-question checklist to decide whether you need to be, elevated to the next level, is that better than using a 3,000 variable machine learning tool using the entire EHR? So there, sometimes using the variable selection is about getting closer to that 5-question checklist while improving performance. Whereas in risk adjustment, variable selection would be much more about trying to reduce this type of gaming. But so I'll stop there, because I could talk about this for hours. But I agree with your premise, definitely, that's why I had that title, familiar questions, different problems. The context, and if I can reiterate that for lots of other different types of research questions in healthcare that we didn't talk about today, the context is so important. And so there we can again stress the dual training, bringing a certain type of tool to risk adjustment, or bringing it to understanding another type of research question in liver transplantation. All those considerations are going to be very different, and understanding the context that something would be used, and also the pipeline of how patients and enrollees are involved in that system is incredibly important.
Great, wonderful. So we have a question here related to something you mentioned about groups needing to be more interdisciplinary. And the question is, when it comes to educating clinicians in a way that they can better collaborate with statisticians and others, what are best practices you recommend, or anything that we can do to encourage that?
Oh, that's a great question. So there's a lot of different types of opportunities to from the clinician side. And again, I don't want to say that that this is a both sides issues. We also need statisticians, machine learning, computer scientists engaging more with the subject matter and becoming dual trained as well. But from the clinician side,
on behalf of doctors everywhere, we're not offended.
Well, since I'm in this other bucket, I really want to encourage other people like me to become dual trained, because there's way too many people that say, I want to use your data, tell me what the X's are and tell me what the Y's are, and I want to throw my fancy tool at it, and I want to see much less of that. From the clinician side, one thing I've seen a lot of people do who are interested in getting more training in machine learning is they've written K awards where they set aside that kind of training. So there's a funding mechanism where they decide to invest in their own training. Other times it's really building and establishing deep collaborations over time. And so, I didn't write a K award to learn more about risk assessment. I started working with health economists, and over time I became really deeply invested in the problem, and I learned a lot about it. So I would say there's not a single path. It depends on, how deeply one wants to go into a second space. But in order to really gain that dual training, there does need to be a substantial investment of time, which I know is constrained by, people are constrained in their time. But in order to really do that, and I think that time investment can just be incredibly beneficial.
That's great, and that really resonates. That there's nothing like a good motivating problem to kind of line up what the next step should be and who to collaborate with as well. Healthcare in general, there's sort of these two dual views of technology, right? On one hand, you say that the quantitative sciences or digital technologies in general, healthcare is way behind. On the other hand, when we rush forward with deploying some things before we're ready, we say, well, we're introducing bias, we're really causing more problems than we're solving. How do you navigate, as someone who does methods development and deployment, how do you navigate this urge to move fast with the need to move slowly enough to not cause harm?
Mm-hmm. I think that's a great question, and it's something that we have to toe very carefully. So with my risk adjustment work, I try to be really thoughtful. No, we're not ready to put this in the risk adjustment system, but there is an incentive that we would like to get there more quickly, because there are currently issues in the existing risk adjustment system, which is not machine learning. So to be clear, when we think about issues of societal bias in our healthcare system, this is not a new thing with machine learning. Standard tools, and there's many examples of this in different clinical risk scores, are perpetuating this racial bias and other forms of societal bias without even bringing machine learning into it. So that's another thing that I'd like to stress, is that there are things that we need to mitigate now that exist already that are not even machine learning. But with risk adjustment, because this would impact just millions and millions and millions of people, and it's not, and we haven't identified it and isolated a singular issue. So there's many groups that are undercompensated. In order to massively shift a system like that, and do any kind of overhaul, it does need to be really methodical. And I've been really, in that space, really excited to invest in learning from other countries' risk adjustment systems and engaging with researchers around the world to understand, who's done what before, and how can we try to get in front of different types of issues. Some of these issues haven't been examined before, but sometimes they have in another context. What can we learn about that in the United States? So I guess a short answer to this would be, if there is a particular issue that we isolate that is somewhat singular in nature. So for example, some of these risk scores for different types of assigning, I don't want to pick out just a particular one because there's so many, but many of these use race in the risk score, and it's very sometimes it's very straightforward to understand whether that should come out at this and whether it should have ever been in the formula to begin with. And there's already been some examination of that over the last months. And so when we isolate issues like that we can quickly correct, I think there's an imperative to do that expeditiously because of the harm caused. But when we're thinking about other types of more pervasive systems, that may not always be possible, because we wouldn't want to change, for example, a risk adjustment system and unknowingly cause harm to many, many other groups. And so I think we can do both. We can intervene on certain practices that are actively harmful, especially when we know that they're actively harmful to a particular group, and we can fix it in a way that we can analyze quickly is not going to have exacerbate harm against other minoritized groups. But in other cases, when we're thinking about bringing new tools to an existing system, there needs to be really comprehensive consideration. And also, we didn't talk today about community-based participatory research, but that's another thing that I think needs to be part of this, and especially when we're thinking about the communities that could be harmed by bringing a new tool or restructuring an existing tool, is who gets a say, which groups are we studying? And we want to make sure that that's not, there's a lot of subjective decisions that happen. And so that's definitely one other thing that I would add to that.
Okay, great, thank you. So we are at time. It is just past 11. There's about 50 more questions out there, but unfortunately that will have to wait till later. So thank you very much, Dr. Rose, and thank you to the audience for your participation and HAI for putting on this event.
Thank you so much.
Thank you.
Thank you to everyone, and thank you, Amit.